السلام عليكم ورحمة الله وبركاته. في noises outside. We could
أحلى شيء السعودية بس في الدنيا عملوا مؤتمرات لا بيعرفوا لك
طيب
بشيء.
let's start. عفوا. Okay, shall we start now? Are we ready? Record is started. So السلام عليكم ورحمة الله وبركاته.
ما بيعرفوش بشيء. حكمة السعودية.
Can you hear? سامعيني؟
بس يبقى فيه حكمة بريطانية وفرنسية.
سامعين
تفضلي. في الباك جراوند other noises.
هذيك المرة لغونا المؤتمر.
ميوت. اوكي ستارت يا مشاعر. توكل على الله.
تمام. Okay, مرحبا. السلام عليكم جميعا. It's nice to have this round today. It's my pleasure to introduce our presenter today, Miss Ala Batok. She graduated, mashallah عليها, from the Royal Melbourne Institution Technology in Australia in 2014. She began her first professional steps at King Abdullah Medical City. And in 2016, she moved on to join King Faisal Specialist Hospital, Riyadh. Since there, she progressed to a senior position in 2020 and has now accumulated over 10 years of a clinical experience. She has extensive experience with advanced radiation technology, including CyberKnife and different modality in Variant, TrueBeam, and Versa machines, as well as complex treatments such as intraoperative radiation therapy since 2020. Her primary clinical focuses has been in gynae and brachytherapy. So please join me in welcoming our speaker tonight. And the talk will be about King Faisal experience, King Faisal Riyadh experience in breast radiation therapy setup and scanning. You are welcome, Ms. Ala, to start your presentation.
Thank you, Masha'al, for this welcoming introduction. My name is Ala Abdel Nasser Batok. As she said, I'm a senior radiation therapist in King Faisal Specialist Hospital in Riyadh. Today, I will present to you the clinical experience in breast radiation therapy setup and CT simulation. We're going to focus more on the patient preparation, positioning, scanning technique, and special consideration if there is any deep inspiration breath hold. This presentation reflect our routine practice and emphasize the accuracy, reproducibility, and patient safety. I'll begin with a brief overview of the breast radiation therapy workflow at our hospital. So I'm going to take you through all these 4 steps that you've seen in the screen. The process starts well before the CT simulation. It's with the treatment planning agreement with the doctor, when the consultation happening, patient education, and verification of the patient preparations through simulation proposal, continuous through the accurate positioning, scanning, documentation, and image evaluation. Each steps are designed and to ensure the constant between the simulation and treatment delivery, which is especially critical for radiation therapy.
Go ahead.
Prior to the CT simulation, a formal treatment plan agreement is established. So it's between the patient and the consultant. Informed consent is obtained after discussion. Can you hear me, guys? Disruption. There's noises ولا okay. طيب in the patient consultation, there is a formal radiation treatment agreement between the patient and the consultant. طبعا there is informed consent is obtained on that day, discussing the treatment objective, expecting benefit, and potential for acute and late side effect for the patient. Patient is also referred to support services such as physiotherapy or social worker, depending on in their individual need. All of the orders that has been done in the clinics and communication are completed electronically through the hospital information system using a standardized simulation proposal. This is how the simulation proposal looked like. This is the one in the right.
How was your exam, by the way? Did you pass? You passed? مبروك ماما, you passed.
Is it possible somebody to mute everybody? Except Ala, of course. Go ahead, Ala.
Yes. Prior to the CT simulation, formal treatment plan agreement has been established. تمام. فالsimulation proposal, as we said before, it's obtained by the consultant on the day of the patient consultation. So this is how the simulation proposal look like, and it's in the left side of the page here. It says the doctor name, what is the treatment intent, how many fractionations, and this information is good for the booking later on to coordinate the appointments accordingly, and it's for also dosimetry and radiation therapy to verify everything through this sim proposal. So the simulation is carefully scheduled by the booking coordination to minimize any delay and to ensure readiness of the patient. The process typically including the virtual clinic, nurse clinic if pregnancy is needed or IV, and simulation appointment itself like the CT simulation. And upon the request, there might be an additional appointment such as MRI or PET. طبعا virtual education is the first appointment that the patient can have after the patient has been consulted by the oncologist. And this virtual education clinic is actually done before the day of the CT. So during the virtual education, the patient is actually informed about the CT simulation procedure and expect what is the positioning and the appointment duration. And if the DIBH, deep inspiration breath hold, is needed, it's explained in advance. And the patient will receive a soft copy of the educational material, including the skincare instruction and DIBH training videos and a voice record, which is shared through the WhatsApp. This early education is very significant to improve patient cooperation and simulation efficiency. طبعا before we begin with the patient, before we bringing the patient into the CT room, we have to do several verification steps. We confirm that a valid simulation proposal is available and it's within our protocols. And within the time frame as well. Any special instruction from the oncologist are reviewed and discussed beforehand before bringing the patient. We make sure that the patient have a proper education and the consent are there. And if the patient need any pregnancy, we verify the pregnancy status. We also ensure that an appropriate embolization device are prepared in advance. In the CT room, the patient identification is confirmed by using a full name and a medical record number. And in addition, an additional verification we obtain it on the CT day is Face ID. The Face ID is not mandatory, but if we can do it, that is awesome because we have a lot of people who have a similar name here in Saudi. طبعا we also verify the treatment site by reviewing the SIM proposal request, checking the electronic prescription from the doctor and documentation on his system, and verbally confirm also with the patient. For the, طبعا we're going to take you through the simulation scans. I'm going to divide it to 3 sections: normal breathing, deep inspiration, breath hold, and an issue in all the scans. So for the CT simulation for the normal breathing, embolization equipment that we usually use for breast is a breastboard and a knee rest. The breastboard angle depending on the site. So if it's a breast, it's going to be 2 straight, and for a chest wall, it's going to be 2 bent. The angulation benefit is to lower the dose for the lung and the heart. Embolization devices, once the patient is on CT and we have verified everything with him, the embolization devices are adjusted, suited to the patient anatomy. So the knee rest position is to support the knee and to prompt pelvis stability. Arm support and arm height are carefully adjusted to minimize any skin fold, and particularly when we are treating supraclav and intermemory chain. Arm position, we need to be aware in the arm position that we are not tensing the area where the surgical area, and to maintain the patient comfort. For the contralateral arm, we cannot excessively open that, and our maximum distance between the 2 elbows is 65 centimeters. And then we're going to go with the headrest. We adjust the headrest according to the patient, and we turn it to the contralateral side. We do also measure between the midline of the laser midline to the ITN, and we note it under the CT as assessment. And we view the scan, and if there is any surgical scar or drainage site, we do wire that before we proceed with aligning the patient. After that, when we align the patient, we're going to use the surface anatomy, SSN, tip of CP, umbilicus, and we're using the laser system to make sure that everything is straight, and we mark it with a pin. And we do take a scout image before we proceed with everything to make sure that the patient is straight and there is no rotation. The CT isocenter, after we are happy, we do our tattooing. So we place the tattoo in a mid chest level to avoid, and we're trying to avoid any scar or any or the contralateral breast tissue. The lateral tattoo are on the same level of the mid tattoo, and we make sure that we place it in a place that is really stable, and to avoid the breast tissue, same level, and we make it on the same level, and we annotate that the ruler measurement in the CT assessment. We also do an INF-AB tattoo, an INF-AB tattoo to make sure that the patient is straight. In case of bilateral breast, we maintain the head to be in a natural position, straight, and the measurement that we are taking is from shin to SSN, and to document it in the CT assessment. The simulation is reviewed and confirmed if the simulation proposal need to be reviewed by the therapist to make sure that there is any DIBH is needed or not. After that, we do take a scout image for the patient, and during the scout image reviewing, we make sure that a symmetry of a chest wall and midline, symmetry of a chest wall, like the measurement for both chests are equal. Make sure that the spine is straight, and the supraclav is not it's not really high and elevated. We make sure also that the shin position is natural, so it's not too high and it's not too low. That is like going to be in the treatment area. Also, from this scout, you can see that there is a skin fold that coming to the shin. In these cases, we just make sure that this fold is actually, we can open this arm more to avoid this fold and to improve the side effect for the patient later on in the treatment. Now we're going to go to the scanning level. The scanning level is from below the orbit superiorly and inferiorly 10 to 15 centimeter inferior from the contralateral breast. In a case of mastectomy cases, like total mastectomy, we go to the level 4 vertebra, and the slice thickness that we use is 2 millimeter with the increment of 2 milli as well. The scan must be reviewed by 2 therapists before we getting the patient off the couch. So you can see here, this is one of the scans that's been taken to the patient. As we said before, we make sure that the falls is minimal, the patient vertebra is straight, mid of the breastboard in here. Make sure that all the BBs are visible on the scan, also in the zero slice. And you can see also here in this sagittal view that the patient is comfortable and her back is not arching. Completing of the CT simulation. Accurate documentation following CT simulation is essential. We record setup details, embolization device used, board angle, arm and head position, and any deviation from standard practice. A setup photograph has been also taken. We usually take an AP and lateral view and with and without a wire in the breast that is being wired to support reproducibility during treatment, and we make sure that the patient privacy is maintained at all time. The contralateral breast is covered and the face of the patient is not included in the images. We're going to move on to the DIBH, deep inspiration breath hold scans. So the RPM system is provide a visual feedback only, and visual feedback only, and it's not connected with a CT scanner. So the DIBH is actually consistent of these 3 elements, which is the infrared camera that is fixed at the end of the CT couch and it's detecting the signal from the marker. The marker block is acting as a breathing monitor detector placed on the maximum respiratory amplitude on the patient, and the camera monitor is like a small screen that reflects our RPM system to help the patient maintaining the breath hold when we couching the patient. So this is how does the system look like in the bed. So the patient is laying down here. The screen is above the patient head. The marker block is where the maximum amplitude is, and the infrared camera is at the end of the table. We have two screen, one inside CT and one outside. One inside to help the radiation therapist to see, the one inside who's coaching the patient, and the outside for the other therapist to control it. When we are coaching the patient for the DI-based simulation, we make sure that the patient is fully relaxed and comprehensive of our instruction. We make the patient breathe normally, make sure they are more relaxed, give them the instruction that their back need to be stable, and they're not to be arched during the breath hold, and to not blow their tummy while they are doing the breath hold. So we do like simple instruction: breathe normally, take a deep breath to your comfortable capacity, hold your breath, and we make sure that the breath is being held for at least 20 seconds, and then relax. We do repeat this process like several times, couching the patient, make sure that they're hitting the same spot every time they're doing the breath hold, to make sure that the treatment, the producibility of the treatment later on in the treatment, inshallah. This is how the RPM system look like. So the upper, we have an upper and a lower threshold. The blue one is the upper threshold, and the orange one here is the lower threshold. Between these two breath threshold, it's a 0.3 millimeter that is between these two lines. So the patient have to hold their breath in this between the 3 millimeter. Our maximum threshold is 3, and our minimum is 0.8. So they cannot go lower than 0.8. That's going to be like a really shallow breath, and they cannot exceed more than 3. That's going to be like a very, very deep that they cannot replicate it again on the treatment. We also, one of the quality assurance is to make sure that the block is actually in the mid of the screen to have equal breathing pattern. Our quality indicator, as I said before, make sure that the patient is relaxed, not arching their back, breathe from their nose, and this is very important, not an abdominal breathing, and hold their breath in a comfortable level. Our DIBH scan, when we are taking it, we do indicate on the description that this scan is done with a DIBH. After acquiring the image, we check the scanning level as we mentioned before, from below the orbit and 15 centimeter or till L4. We confirm and we make sure that the scan, when we take the DIBH scan, we do review it against the normal scan to make sure that there is a DIBH happening actually in the patient. If the patient drops out from the threshold during the scanning, we immediately stop the scan, recouch the patient, repeat the scan once the patient is stable and achieve the threshold. طبعا when we evaluate the DIBH scan, so this is a free breathing and this is a DIBH, you can see that the lung volume is getting bigger, the heart is displacement, and you can tell that there is more breathing in here. So this is a really successful DIBH scan. Issues that we faced upon simulations, like large breast patients. So what do we do with a large breast? We have two approaches. We have changing of a tattoo placement approach, and the second approach is the breast cup. So talking about the first approach, we keep the midline on the in the mid between the two chests, and then we lower the rolls to a stable place. And then we take the records for the mid-AB tattoo and the rolls of the roller position from the breastboard for the mid and the two rolls. And we record both of them. And we keep the MF-AB tattoo as it is. So this is our first approach. The second approach is using breast cup. When we using the breast cup, we're considering that we are using the appropriate size that fit the patient anatomy, secure the cup, and when you're securing the cup, we secure it in a comfortable level of the patient. We do mark and we do our mark and label of the orientation clearly in this cup. Our limitation is that we have facing a skin reaction during using this breast cup on the patient, and it's not comfortable toward the end when the patient have a lot of side effect of the treatment. Our second challenge is this limited arm mobility and seroma and surgical wound. to be honest, like if we have any of that, if the patient is struggling with arm mobility, we ask if they have a physiotherapy or if they have not have physiotherapy, or if they can manage the pain. If they can manage the pain and the consultant want the scan to be done, we do the scan with the painkiller given to the patient, or sometimes we do delay the scans until the mobility improves. For seroma patients, also depending on the doctor judgment, we bring the doctor, sometimes do a short scan before we do a full scan for the patient, bring the radiation oncologist, make them sit with us, explaining that if they are happy with the scan to be done or not, and depending on that, whether to proceed or delay. Also, cervical scars, we make sure that the wound are not open and properly healed, and if not, also the radiation oncologist is informed and to determine whether to proceed or delay simulation. So to conclude, this is our practice in King Faisal Specialist Hospital during any breast simulation scans. I hope you have enjoyed this presentation. Thank you so much for listening.
Thank you, Ms. Ala, for this informative and insightful presentation. The door is open and for any questions. Any questions? Just go ahead.
بالنسبة للي سألوا عن المحاضرة, I can give it to أحمد قطان, and you can have it إن شاء الله.
Thank you, Ala, for this great and well presented talk. Thank you very much.
You're welcome.
I have a question for you, Ms. Ala.
Yes.
I know you said that you face some issues with some patient, like mobility or difficulty of sometimes holding the breathing. Did you face a situation when you patient cannot keep the breath and treatment takes longer than unusual, and you after that you hold the treatment to re-CT and rescan?
Yeah,
you
that's
came
why.
through.
Yeah, so you're saying that the patient is actually go to treatment and then they cannot hold their breath as they did in CT, correct?
Yes, true.
Okay, that's why in our protocol, from the beginning, we do a normal scan, which is a free breathing, and a DIPH scan. So let's say the patient came to treatment and they cannot hold it anymore and they cannot achieve the threshold that they do. We go على طول with a normal scan approach after the oncologist agree. And we sit with the oncologist, but we do like several approaches before we do that. We go and review the CT scan. If we see that the lung volume are not matching, or it's مثلا higher or lower than the CT, we play with the threshold شوية. And we either lower it by 3 millimeter, and the senior is on top of that, and the oncologist is aware. And then we compare the CT of that treatment with the original, the CBCT of the treatment with the original CT. And we say if these are matching and the oncologist is happy, we're going to continue with a lower threshold than the CT. If not, after several fractions, like 1, 2, 3, we try with the patient. If if they cannot at all reproduce that, then we're going to go with the normal scanning. But we're going to try first to achieve that DIBH scan before.
Okay, excellent.
لا.
Anybody else has a question?
Masha'al, there are a couple of questions in the
Doctor.
comments.
Masha'al, how are you?
Alhamdulillah, أهلا.
يعطيك العافية آلاء. Thank you so much محاضرتك. أنا لؤي الواكد سوبرفايزر راديوثيرابي مركز الحسين للسرطان. I have one question آلاء. What about prone position in the patient included huge breast or big breast? About this critical region in the more efficiency about the big breast in the King Hussein Cancer Center. I use prone position, not all this supine position.
And my presentation is only consist of the King Faisal Specialist Hospital experience for breast, and we had never done prone breast before. So I don't know if, unfortunately, I don't think I can answer your question, but we have never done prone position. So
All the patient supine position?
all the patient are in supine position.
Yeah, okay. Okay, thank you, Ala. Thank you.
في كمان لؤي I think has a question.
Yeah, أنا لؤي. Yeah.
أنت لؤي. أهلا يا لؤي. معلش. I'm learning how to use the system.
Okay, thank you.
That's very good. It's nice to have you.
السلام عليكم.
محمد.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
عليكم السلام.
This is Zaka Khan from Pakistan. First of all, I want to appreciate that's a very wonderful presentation. And but I have one question regarding your presentation, and it's about the use of the breastboard in this CTSM and also for the treatment. So, is there any beneficial, or are you getting any benefit by using the breastboard? Because most of the centers are using a vacuum bag with the wing board, along with the wing board. So we are also doing this kind of thing, and while our patient remain flat on couch. So that was my question. Thank you.
So we are using the angulation and the breastboard to lower the dose for the lung and the heart. Mainly with a conventional technique like a 3D technique. When you're using the angulation, you will minimize the lung and the heart dose. But we also do the rapid arc and edema treatment, which is also considering of lowering the heart dose, but also to make it more efficient, we do the IBHs. So I think maybe I did answer your question in that matter.
Yes, Dr. Ala, thank you for the presentation. Question, left breast. أنا أفضل إنه نعمل له DIBH ولا عن طريق SGRT يكون أفضل؟
Service guided, our hospital, inshallah, they are planning to get it in future. So it's on our future plan. But for the time being, we're doing the DIBH patient to minimize the heart dose.
More people raising hands. في other people. Muhammad, I see.
السلام عليكم ورحمة الله.
تفضل. السلام عليكم. السلام.
Thank Ala for your great presentation. It's a really good experience that needs to be shared with others. I would like to ask, when it comes to the bilateral breast, do you guys face any difficulties with this, and how do you guys handle it? Also, in the touching of the questions of Mr. Luay, when you face patients with huge breast and you see there is a skin folding, how do you handle these cases, guys? Thank you so much.
I have mentioned in the presentation we either lower the tattoos for the patients, and if the skin fold is really problematic and it's really huge, we do the breast cup technique. And for the first part of your questions, can you remind me what is the question?
In the matter of the bilateral breast, when you guys say you keep the chin in the natural position,
correct.
Do you guys face any difficulties with this, and how do you guys handle it?
So when we do the bilateral breast, the chin is extended and is measured and is being consistent. And during the CT scan, we only do one hit of a scan. خلاص. We make the chin straight. We don't need to do 2 different scans for the patient. So one scan taken, and if the DIBH scan is needed according to the oncologist's preference and the beneficial of the patient treatment. But during the treatment, they either do rapid arc treatment for both, or they divide it to 2 separate sites, like right breast and left breast. But I had never. It's been okay. I never had an issue with it. And then when we're treating, we take separate images if they are separate site. But if it's treated as a one goal with one plan with rapid arc, we take a CBCT image, make sure that all the areas is covered, and then we do the treatment. Just to mention that our couches in Avarian and in Versa, they are doing a 60 couch, so we can correct for any rotations.
Okay, thank you very much. Zainab, I could see her raising her hands.
Yes, thank you, Ms. Ala. I have a question. When you place the border for the breast, do you have the protocol for the oncologist to come and check and verify the border for the breast, or you only just do it for the therapist, place them by themselves and then scan? Thank you.
For the border, do you mean the border on the after the plan has been done and done in the treatment, or the border for the scan?
Breast border during simulation. You know how sometimes we wire the scar when needed? Some oncologists ask to place wires to define the breast borders. Do you do that at your institution?
No, we don't. So we have an agreement with all the oncologists where they want the scan to be to be at, and this has become in our protocol. So it's below the orbit to the 15 to 10 centimeter, and
it's not the scan border, but rather than the breast border.
We don't give them a breast border.
You don't do it? Okay, thank you.
At some centers, they still wires the breast tissue borders, but others, they follow the landmarks. It depends. King Faisal Riyadh, as I remember, they used to go with the landmarks. صحيح آلاء?
Okay.
Any other questions? Okay, Hiba, you could go ahead. Hiba, you have a question?
Yes, sorry. I thought it was mute. My question is, what is your protocol? This is Hiba Suleiman Faris from Senior Radiation Therapist at King Fahad Medical City. My question is, what is your protocol, imaging protocol? I mean, for the breast, normal and the IBH. Maybe you mentioned that, but I think I missed it.
مرحبا هبة هلا والله.
هلا
The breast protocol, as long as if it's a rapid ARC treatment, VMAT treatment, we do automatically we do a CBCT for the patient. And
daily.
Daily, correct.
Okay.
Daily. And if they are 3D conformal, we do per kV image, also daily. And we do also verify the border with an MV, first refraction, and then weekly.
Okay.
For the 3D conformal. But the rapid ARC, it's a daily CBCT.
Yes, and the IBH you do during for the whole fields, or do you?
We go with the technique. So if it's a 3D conformal, we do the same KV images and MV.
Okay.
The first 3 days and weeklies, or if it's a rapid ARC or a VMAT, it's going to be a daily CBCT.
Okay. Okay. Thank you very much. Thank you.
Zainab still raising hands. Is that a new one or stuff from previous one? حسان اتفضل. Go ahead. More question? Okay. مناهل. تفضل مناهل أحمد. مناهل. I don't think مناهل could hear me. مناهل تفضل.
السلام عليكم.
وعليكم السلام.
This is Manahil from King Fahad Specialist Hospital in Dammam. Just I have one question. Regarding the patient with the arm limitation. You mentioned that in your presentation, the patient has to go for physiotherapy first before simulation, or you are doing a backlog. How you are doing that, the backlog for the arm immobilization?
So let's say if the patient is struggling, we did our maximum. She went to physio, we give her painkiller, and she cannot raise her arm. So
yes.
we're taking out the arm support, and we place a backlog to help the patient sustain her arm position.
So you are fixing the backlog in the breastboard.
Correct, but it's going to be a really tiny backlog, not the big, huge one. So it's only going to fit through the arm and maybe the head, but nothing else.
Okay. Okay. Thank you.
No worries.
Okay, so we came to the end of our round. Thank you, Ms. Ala, for this great presentation. And we truly appreciate sharing your experience at King Faisal Riyadh, particularly your valuable perspective on breast radiotherapy setup. It was a pleasure to have you today with us. Thank you very much. Excellent.
And have a lovely night. Thanks.
Inshallah. Thank you very much.
Thank you, everyone. Thank you.
Thank you, everyone.
Thank you all.